Welcome everyone to the thoraco respiratory module, depending on your preference. I am joined here by my lovely co-host, Dr. Emily Rose, for this EMCert Module Mastery program. Now, we are here to help guide you through one of these ABEM EMCert modules. And remember that this is an open book exam.
I love those.
I know, it's very generous of them to give us that option. And so we've provided you here with a series of chapters to kind of navigate through the things we think are most likely to appear on this exam. Now, we have not taken this exam. We don't know exactly what's going to be on this exam. And even if we had taken it, we wouldn't disclose what's on the exam per ABEM's rules. But we have not taken it. So we've done our best job to really encompass all the things, chest, respiratory, trauma, peds, all kinds of areas where we think that they'll probably go with this subject. And because we want to make sure we provide you with a very complete reference, we provided you with a slide set that's very comprehensive, that you should have open when you're taking the test so that you can search around, look for different algorithms, different medical decision-making tools, clinical guidelines, things like that, that we have included in this slide set that we hope will be helpful to you. Now remember also, a point is to look at the ABEM website and go to the key advances section. That section will give you what kind of things, there's recent clinical guidelines that they want you to know, there's papers they want you to know, things that ABEM will provide for you there that could be on the exam. So please go and look at the key advances section on the ABEM website before you take this test, so you have that available to you as well. Those are easy questions to get right because they're telling you what they think is important. So we're going to get into this thoraco respiratory module. I'm really happy to do this with you, Emily.
I'm excited to be here. Thank you.
We'll go. Ischemic chest pain, my goodness. This is something that we talk about, see, worry about all the time. It's one of our most common differential diagnosis players. And so let's talk about some specifics of ischemic chest pain, which I think is very, very high yield for the exam. Now, certainly when we're talking about dangerous chest pain, there's a classic differential. And if you look down the left side of this table, you will see those diagnoses that we consider day in and day out. We've got acute coronary syndrome, we've got PE, aortic dissection, pneumonia, esophageal rupture, pneumothorax, pericarditis, perforated peptic ulcer, remembering that things that present as chest pain can be pulmonary and they can be GI as well. And then we walk through on this grid all of the things that, again, are the classic descriptors for this dangerous causes of chest pain. What does the chest pain feel like? What is the quality of the chest pain? Where does it radiate to classically? And then what other signs and symptoms may a patient complain about that would make one of these diagnoses more or less likely? All laid out for you here. So it's a nice sort of summary of all those classic dangerous things that can cause chest pain. Now, really, the actual differential diagnosis of the patient who presents with chest pain could be any of these things. Many of these things are not so dangerous. You know, we go all the way down to anxiety and panic attack on here, which is, of course, diagnoses of exclusion. But there are a lot of things that it could be that are not so serious. We've got costochondritis here. Could it be a rib fracture? It's going to be in the right clinical scenario, of course. You know, could it be valvular disease? We're going to walk through a lot of these conditions in this module, but this just reminds us that when the patient presents with chest pain, it could really be a lot of things. Things from GI to pulmonary to herpes zoster. I mean, who knows? We have to consider all these things and then narrow it down based on our physical exam and what we see in front of us. Now, for our pediatric chest pain patients, there are some specific things to know here. Now, don't forget that even pediatric patients could have an MI or have angina. They may have a vasculitis or abnormal anatomy that could make those things still on the list. Pericarditis is certainly on the list. Is it trauma? Could it be a pneumothorax? Is this a patient with sickle cell who's presenting with something like acute chest syndrome? Kids can have PEs too, so we can't take that off the list. And then we have to think about things like malignancy, looking for something like a mass. So this sort of gives us sort of what are the highlights in pediatric chest pain, Emily?
Yeah, and I think I have to add a couple of things. I love taking care of kids as well. But chest pain is a very common complaint in children. Like, that's sort of the bad news. The good news is the vast majority of it is not cardiac and it's not serious. But it can happen. You can never be too young to have an MI. If you have a congenital anomaly of the vessels, you can actually have an MI at 2 months of age. Kawasaki's disease, we'll talk about this in further slides, but Kawasaki's disease is a huge risk factor for early MI, young MI, even childhood MI. So we have to think about it, but not get unnecessarily worried about it. A good history and good physical exam can really help you sort of narrow down the differential. The other thing about it, though, is that parents are very, very worried. My child
course.
has chest pain. They're very, very worried. And actually, a third of all chest pain, pediatric chest pain complaints, those patients have more than one ED visit for the same complaint. So a lot of being informed, a lot of reassurance, giving them the sort of the statistics. Basically, if you have no significant risk factors on your history, your physical exam's normal, you pretty much have zero chance of having a cardiac disease, but you have to do that good history and physical exam. And kids miss school because of chest pain. So the pain is real.
Yeah. Now, what about acute coronary syndrome? Clearly, this is, one of the top things on our list, especially in patients who are, middle age to older age. And what is acute coronary syndrome? Well, it means that we have reduced blood flow to the myocardium, and there are really different ways that it kind of plays out. We've got our patients who are STEMI, right? We look at that EKG right up front as quick as we can. We look for those ST elevations that qualifies them for a certain pathway of care. We've got non-ST elevation MI, and then we have patients who really have unstable angina. They have reduced blood flow that seems to be escalating in its pattern. And then there's a fourth, obviously far more common category, which is someone who has a non-diagnostic EKG. Their troponin, their biomarkers looks negative, but we're still worried about it. We're still worried that they could have a lesion that is causing decreased blood flow. And that is really where we struggle in this category for sure. And so we have developed, we being the global we, not me and you, Emily, but the population at large and our researcher friends have developed ways that we can kind of sort through this category and risk stratify those patients into, are they low risk, medium, high risk, very high risk, based on many factors to help us sort through what to do with those patients. And that's really what all those clinical guidelines are helping us to do.
And what we really want to do is we want to take the patients that are developing or experiencing some ischemia, we want to prevent infarction. So we really want to pick these patients up, and that's why there's so many slides on this. There will be exam questions on it, because we care about this clinically. It is our duty to not miss this for our patients.
So the primary evaluation in the ED, obviously we're doing a history, we're doing a physical exam, we're getting that EKG, we're getting that first set of biomarkers, and then we kind of move into a different category. Is this probably not ACS, in which case we're going down some other pathway, or we're actually moving into the space of, this looks like it could be acute coronary syndrome, possibly, or even definitely. And then I'm deciding, am I admitting them to a coronary care unit, or am I putting them in an OBS unit or an inpatient unit to get some more stratification, serial EKGs, serial cardiac markers, objective testing like a stress test, for example. So these are kind of the spaces that we move into, and we do this day in and day out. So we are all familiar with where we're going with this.
Yes, we see a lot of chest pain.
Yes.
And I'm really grateful for all of the researchers out there that have just toiled to create risk stratification tools and help us score and help us just have a little bit more confidence or a little bit more direction in risk stratifying patients. So some of the best well-known and well-studied are the heart and EDAX. We use the heart in our emergency department. Both really identify patients that are less than 1% to 2% 30-day risk for a major cardiovascular event. Now, we would love to get this to zero, but it seems like over the years we've tried very hard. It seems like less than that is pretty impossible, because we would be way over-diagnosing, exposing people to harmful interventions if we do that. So really, in summary, a heart score of less than 4, and we'll go over the specifics of this, or EDAX less than 16 suggests that risk of less than 2%. Now remember, there's the heart score, and then there's the heart pathway, and we'll talk about these in the next couple of slides. The pathway is applying that heart score plus interventions, getting 2 troponins 3 hours apart. And you can use these guidelines to just more confidently disposition patients. It can give you that sort of reassurance that, listen, we're doing the best we can. There are going to be, about 2% of patients that do fall out, but that's why we give good return instructions. But that sort of is a overall global risk versus benefit, helping the most people without causing too much harm.
For the purpose of the exam, certainly these risk stratification tools have been out long enough and are widely used enough that we are expected to be familiar with them. And I would guess that they will wade into this water about how much you know about the limitations of these tools, how you use them, et cetera.
And another take-home point about these is that if you have already known coronary artery disease, or you have higher scores, you really should take that seriously. Those patients are at higher risk of having complications. So you want to observe them, get even more troponins, get some sort of imaging or functional testing to assess what's going on with their arteries. So the heart score, again, this is not something to be memorized, but it's here for reference. There are a couple of features that may be a little bit subjective. Somebody may say, oh, your history is a little bit, highly suspicious versus moderately suspicious. There is an element of subjectivity, but there's some consistency here. So you basically take features from your history, EKG, age, that's not subjective, risk factors. I feel younger than I am, though, so maybe we could add that. Yeah. And then risk factors, and then actually you have to have a troponin resulted to adequately, appropriately apply the score. And then you take that score and then you plug them into the heart pathway. And you take a look at the EKG, you look for findings consistent with ischemia, ST, T-wave changes, or it may be a frank STEMI. If it's a frank STEMI, then you immediately jump to your STEMI protocol. But in most cases, if you have EKG abnormalities, it's fairly subtle, and then you kind of plug that in, get a troponin, and then you reassess them. And then those a little bit, higher risk patients, you need some sort of further assessment and intervention. So on the EKG, I think a big important take-home point for us clinically, but this may also come up in the exam, is that the EKG can change, and dynamic changes are definitely possible. So just because you have one EKG that's totally normal, it doesn't mean it's going to be totally normal 15 minutes later, an hour later. So if you have new symptoms, new pain, absolutely don't hesitate to get another EKG. But get an EKG very, very quickly, because time is hard, right? We want to prevent ischemia from developing into infarction. So we want to recognize this as soon as possible. So high-risk EKG findings, of course, are regional ST elevations, regions of the heart known to be perfused by these arterial circulations. You look for reciprocal changes, any T-wave inversions, or dynamic changes. That's of concern as well. And this is highlighted here. I think this is an important point that we've already emphasized, that EKGs can change. There is some dynamic changes that can occur literally right in front of you. I've seen that many, many times and been very grateful I got another EKG. But that may be something that if you're like on the fence about a patient, I'm not sure what I should do about this, or I'm not sure if I love these, what they're telling me about their chest pain, getting a repeat EKG during their ED course or even before discharge can give you another data point to either reassure you or increase your concern. That may change your disposition. So they're low risk if they have a normal or unchanged EKG. Again, that's a relative term. Remember, you still can have a significant percentage of patients can go on to have some sort of acute coronary syndrome.
Remember that 10 minutes is the AHA recommendation. Tough to get an EKG within 10 minutes on all your patients from the time of arrival, but that is the benchmark that you're usually being held up to. So remember that 10 minutes is the goal.